Well, kia ora koutou katoa, no mai haere mai ki te manatu hauora. Nice to see you all back here for today's update. Thanks very much for coming up. So today, a quick update on our Omicron response, including some of the key numbers from today, an assessment of where we are in the outbreak and what we can expect next. And then I'm going to hand over to my colleague here, our care in the community lead, Dr. Joe Bourne, who will give an update on that aspect of the response. First of all, just some of the headline numbers from today. The detail will be in our standard 1 o'clock media release. There are 20,907 new cases today in the community, and the 7-day average of cases is 17,020. Unfortunately, we're reporting 15 new deaths today, and the 7-day rolling average of deaths related to COVID is 10 now, which is the highest it's been. We have 1,016 people in hospital today around the motu, and of those, 25 are in intensive care or a high dependency unit. Now, last Friday, Dr. Anthony Jordan from the Northern Region Health Coordination Centre described that up there they were increasingly optimistic that they had seen the peak in Auckland. Our latest analysis confirms that COVID case numbers have indeed passed their peak in Metro Auckland and are on their way down in all 3 district health boards, counties Manukau, Auckland and Waitemata. Case numbers across Auckland today totalled 4,291, so about a third of what they were on the 4th of March, just 2 weeks ago. Our analysis also shows that the increase in case numbers across the rest of the country is also slowing. So in the 7 days to the 20th of March, case numbers nationally, and we've taken Auckland out of this, increased by just 1% compared to a 44% increase in the 7 days up to the 13th of March. So a much slower rate of increase around the country outside of Auckland. So saying, the pattern does differ by district health board. There are encouraging signs that the case numbers are peaking in the region we call Te Manawataki, which is the Midlands region, and in the Wellington region, but case numbers are still very much on the increase in the South Island. I do have a few slides to walk you through today to just provide a bit of a picture of key features of the outbreak in Auckland and across the motu. First of all, this is an updated slide on the case numbers in the northern region, which includes the 3 Auckland Metro District Health Boards and Northland. And you'll see today that the line of case numbers is very much following that high scenario, transmission scenario. It looks like it's in the medium to low now, but actually it's just following the trajectory of that blue high transmission curve in behind those other 2. Now, the peak did go higher than that original modelling showed. It's not clear exactly why that is. It may well be because most of our infections in New Zealand have been from this BA2 variant rather than the less transmissible BA1 subvariant that the modelling had been based on. Now, alongside this, we can also see that hospitalisations in the northern region are levelling off. They're now sort of past the peak that they were in the Omicron surge. Hospital admissions do fluctuate, but we're watching carefully, and our expectation is that they will start to drop as the week progresses. The average length of stay for people on wards in the Auckland hospitals who have been discharged is now 3.2 days compared with just over 2 days last month. And the average stay in intensive care is 5 days. This increase in average length of stay reflects that we're now seeing people who are needing longer care. They may even be over their COVID infection, but they've got residual symptoms that need to be managed, often from underlying conditions. Early in the outbreak, we saw younger people going into hospital, often treated and discharged just overnight. The third slide is also hospital admissions in the northern region hospitals. And what you can see here is even though those case numbers in hospital in the northern region are staying high, the number of new admissions each day is dropping. So you can see those blue bars almost following that blue high scenario that's in behind there, that high transmission scenario. So the number of new admissions each day is dropping away quite quickly. But because those people who are in hospital are sicker and require longer care in hospital, the total number of people in hospitals remaining quite steady. There's also been a drop in the positivity rates of people presenting to emergency departments across the Auckland region. So they remain highest at Middlemore Emergency Department, but they've fallen from 40% last month down to 28% now. Likewise, at Auckland Hospital over that period, they peaked at about 30% and they're now down to 22%. Waitemata's positivity rate of people just presenting to ED, all of whom are tested, Waitemata is at about 18%, that's quite steady, whereas up in Whangarei it's at 16% and still on the way up. Pleasingly, the positivity rate at Starship Hospital in Auckland, the Children's Hospital, has gone from 35% down to 21% now and on the way down. The final slide I've got is just showing hospitalisation numbers across the motu. This is active cases in hospital, total. The blue bar is those that are in the Auckland regional hospitals, and you can see early on in this Omicron outbreak, most of them were in Auckland, that's where it started, but the proportion of total admissions that are in the Auckland region hospitals has dropped away over this last few days or week or two. So the admissions in the rest of the country are growing, and we will continue to see them grow. So I don't think we have peaked yet in terms of our total hospitalisation. That will generally be 1 to 2 weeks after the case peak. And just thinking about hospitalisation rates, if we think back to the Delta outbreak in Auckland, over the period of that Delta outbreak, the hospitalisation rate was around 8%. Whereas in this Omicron outbreak in Auckland, it's been about 0.9%, so under 1%. So this confirms Omicron less severe in terms of symptoms, but of course much bigger impact on hospital and community services just because of the sheer number of cases. Now that hospitalisation rate will appear to increase over coming weeks, because as the cases drop, yet people remain in hospital, we'll see the denominator decline much quicker than the numerator. So we fully expect that rate to increase up to over 1, even 2%, and hospitalisations will decline, but more slowly. Likewise, it's important to remember that the number of deaths each day is also likely to increase and will take longer to decline. There is a delay between the case numbers, of course, and hospitalisations and deaths. Our ongoing reporting will continue to indicate where we know the split between deaths that are because of COVID and those that are in people who happen to have COVID incidentally. And final comment just on our hospital and health system. I know that staffing shortages due to isolation requirements are a major pressure on the health system, on top of the number of people who are being looked after into the community, including in aged residential care. We're seeing that real pressure on our hospitals, and I do want to again pass on my huge thanks to my colleagues who are working so hard to ensure that everyone gets the care they need, under considerable pressure and often with up to 15 or 20% of their fellow workers away because they have COVID or because they are isolating themselves or caring for whānau members. So, what might we expect further out? International experience with Omicron suggests that in New Zealand we can expect to see cases will likely remain in the low thousands each day for some time. Hospitalisation numbers, as I said earlier, will likely peak within the next 2 weeks or so and then trend downwards during April, but likely relatively slowly, and we will expect to continue to see regional variation there. Overseas experience with hospitalisations is variable. In some places the rates have declined at the same rate they rose, while for others much more slowly. We can expect ongoing waves of COVID with elevated baseline levels of case numbers and hospitalisations. Looking across the Tasman here is quite instructive. The number of people hospitalised with COVID in New South Wales never dropped below 950 after their first Omicron wave, even as the peak of cases waned. It's now back over 1,000 as case numbers start to increase again. The 7-day average in New South Wales is around 18,000 cases per day. In contrast, in Victoria, the number of hospitalisations declined down to around 200. and remain steady there. They're not going up again, even though their 7-day average number of cases is about 7,800. So two quite different pictures. Now, there may be some definitional differences there, but what it shows is that we can expect to have both the residual cases in the community and people in hospital. You'll be aware case numbers globally have started to rise again in recent weeks, and there are increased case numbers across the UK, with Scotland hit the hardest by a surge of the Omicron BA2 subvariant. Case numbers there are just under their previous peak, and hospitalisation figures at the highest they have been since 2020. Globally, it's likely there will continue to be further waves of Omicron, and likewise there will be new variants of concern with unknown severity, and we will face those as other countries will. Now, all of this shows that while our current Omicron wave is receding, we clearly need to keep our wits about us, and that COVID isn't done with the world just yet. However, we do continue to have some advantages here in Aotearoa. Countries experience another surge in cases from Omicron appear to be more affected by the more transmissible Omicron BA2 subvariant, and in New Zealand, that is the vast majority of our cases at the moment. So we may not see quite the same surge that other cases are seeing at this point in time again. We also know that other infectious diseases, respiratory diseases, particularly flu, and in children RSV, that's respiratory syncytial virus, could generate additional demand from the health system over winter as our borders reopen. We are looking at what's happened with these two viruses during the Northern Hemisphere winter to try and gauge what the potential impact could be here. But meanwhile, we're not taking any chances. Our influenza vaccination program starts in early April, and as you will have heard, we have ordered extra vaccine and widened the criteria for eligibility for free vaccination. We're also looking at the role of a possible fourth dose of the Pfizer vaccine for vulnerable groups, including older people, and I'm expecting advice on that this week. However, our most significant advantage continues to be our high COVID-19 vaccination rate. This remains at the heart of our ongoing efforts to protect ourselves from the worst effects of COVID-19 through the ongoing pandemic, particularly for our most vulnerable population groups. I continue to strongly encourage everyone who isn't already to be up to date with their vaccinations, which includes getting a booster dose when it's due. There is no doubt vaccination saves lives. So, in summary, we can be cautiously optimistic. We're past the peak of this outbreak, particularly in the Auckland region. We don't know exactly how fast cases and hospitalisations will fall, and with colder winter months ahead, we need to remain vigilant to COVID and other respiratory viruses. So, once again, I encourage everyone to ensure they are up to date with their full course of COVID vaccination and to get the flu vaccination when that becomes available in April. I'm now going to hand over to Dr. Bourne, who will make some comments and update you on our Care in the Community program, and then we will take questions. Thank you.
Kia ora koutou, and thanks for the opportunity to talk a bit about COVID care in the community and how we're supporting our communities to be safely looked after at home when they're able to do so. As Dr. Bloomfield has just indicated, whilst we may be reaching a peak of COVID cases in the community, we're still seeing extremely high levels of engagement with people with general practices that are very much at the forefront of providing care. So compared with last year, general practices are having 15% more encounters with people each day compared with 2021. So those encounters may be face-to-face visits or telephone encounters. General practice and other primary care providers are constantly adapting how they're working to be able to deal with the number of cases that we're seeing. Those increases in activity for general practice aren't the same across the whole country. And so we're seeing the case numbers changing, that being mirrored in the number of encounters that we're seeing in general practice. So the numbers in Auckland are now starting to return to their normal levels compared with last year. But an area like the Hawke's Bay is seeing 33% more people than they were at this time last year. And then if we go into the South Island, Canterbury's now sitting at 30% more encounters each week compared with last year. And we would expect over the coming weeks for that trend to continue across the South Island. The increase in demand is being accommodated by general practice, urgent care providers and community pharmacies. And they're managing to do that despite their workforces also having to isolate, like hospital workforces having to isolate when they contract COVID themselves. But within those environments, they've got a smaller pool of staff, and so that can be really pretty challenging. But I guess what I want to do is reassure New Zealand that those vital services remain open. They don't have an option to close, they're remaining open. To support that, the Ministry of Health is opening up a database that we have of people who have made themselves available for clinical and non-clinical work to help with the response, and that's been utilised through the vaccine programme to date. So we're notifying primary care providers that that's another resource that they can tap into if they think that they need more additional staff, which I think is going to be really appreciated as people are understandably getting tired having been living with this for the past 2 years. I just want to put a reminder as well that not all illness that's being dealt with in the community is COVID. So the rest of the clinical services that we have in our communities are still available. Excellent healthcare continues to be delivered by primary care providers every day. I was working last Friday and I had to do a home visit to somebody who was unfortunately at the end of life, nothing to do with COVID. She has an advanced cancer, and what she needed was care provided in her home. Despite all the restrictions that we have around COVID and the necessary infection prevention control measures that are in place, she had already been visited by a hospice nurse. I visited her at the lunchtime. While I was there, another person came in to deliver the hospital bed that she required, and before the end of the afternoon, she was receiving medication that she needed to keep her comfortable at that time. So reassuring again that those services remain available and we need to keep providing them to people who have other conditions apart from COVID. Just wanted to update around the self-assessment form that we have that's available for people to complete when they test positive with COVID. So people receive a text message and a link to a self-assessment form. That form is vital for allowing our care coordination hubs to understand any needs that those people may have in the community while they're isolating. We've now introduced a place where people can declare a disability that they're living with, so that can be flagged and made visible at a care coordination hub so that they can be prioritised for contact by the coordination hub to find out exactly what needs they will have during their isolation. Another part of that form that has been added is the ability for people to flag if they have a problem with where they're isolating. So an example of a case that we had recently is a woman who had recently moved from one part of the country to another. She didn't have secure accommodation. She tested positive for COVID, and while she was being assessed, it was identified that she would be isolating in a car. The clinicians in that case were able to contact the local care coordination hub, who could identify a camper van which she was given access to, and she was then able to park that on a friend's property so she could isolate safely. In addition, a local kaupapa Māori provider made sure that she had all the food and other supplies she needed for her isolation period. And I just want to reinforce how important it is that we do continue to isolate when we've either got COVID or we are a household contact. That remains a vital part of us being able to protect those people who are more vulnerable within our communities, and so that we can, where possible, prevent the spread or at least slow the spread of COVID-19. So I just wanted to take an opportunity just to reinforce what the guidelines are around isolation. for both people who have COVID and their household contacts. So a person that has COVID needs to isolate for 7 days, either from the day they developed any symptoms at all, or if they've had no symptoms, from the day they test positive. Household contacts need to isolate for exactly that same period, and they're encouraged to get a swab at day 3 and at day 7, and at any other time during the isolation period if they develop any symptoms. If a household contact becomes positive during that isolation period, their isolation begins for the same rules as the person who was the first case in the household, either when their symptoms started or when they test positive. At the end of the isolation period, a person who has had COVID then doesn't have to isolate again if they become a household contact for 90 days. They don't have to test again for the first 28 days, but if they do get symptoms during that time, then they do need to test, and that should be by a RAT test, not by a PCR test. A person who's been a household contact and has never been positive at all has a 10-day period where if they don't develop any symptoms and don't test positive themselves, if they become a household contact again, they don't need to isolate. So that's 10 days from that point. Now, these rules may feel incredibly complicated when we're going through them, but that's because isolation remains an important part of our response and the ability to protect those who are most vulnerable in our communities. So we ask people to continue to follow that guidance during this period. Once again, I just want to take a moment to thank all the people who are working out in our communities, supporting people, working under considerable pressure, but we see them rising to that challenge on a daily basis. So thank you.
Dr. Bloomfield, you were talking about a fourth shot for the vulnerable. At this stage, is your thinking just for people who have underlying conditions, or could that be extended to the wider New Zealand population?
Thanks. So I've asked for advice specifically for vulnerable populations, and especially looking at what other jurisdictions are doing. So older people with pre-existing conditions, in particular, I'm most interested in, especially as we go into winter. But I have also asked whether the offer should be extended to other groups, and in particular, I'm thinking here of the health workforce, who would be at a high risk as we go into the winter period. And they were one of the first groups to be opened up to get their booster shot back in December. So we are seeing overseas that the effectiveness of that third shot does start to wane. And thinking of those groups that got their shots first, they were our older people, our other vulnerable people, and our health workforce.
So taking the next logical leap after all of that has been completed into vulnerable, and then the frontline workers, would the rest of the population be gearing up for a fourth shot after that?
Not necessarily. And at the moment, I don't think there's any country, perhaps Israel, that's offering it more widely to the population, but even then, I'm not sure. So at this stage, we're going with the emerging evidence, which is those higher risk and vulnerable groups.
And when will we know that that will be the ministry's advice?
I'll get the advice this week, and we'll discuss it with ministers later in the week, and then, of course, the decision will be theirs, and you could expect announcements sometime after they've made a decision. But one of the aims we have is to look at whether we could vaccinate those groups alongside the flu vaccination, so, 2 for 1.
How early do you imagine we could see that for drugs then getting rolled out? Just before the end of the year?
Ahead of winter, so alongside flu vaccination. So if the decision is taken, our aim would be to do that through April, May, before we head into winter.
Just on the sort of hospital staff, primary care staff, and presumably age residential staff also maybe COVID or isolating, can you give a sense of how much pressure that is putting on the health sector?
There's no doubt that in addition to the people who are in hospital and the additional people being seen in general practice that Joe covered, probably the biggest pressure is the staffing one because of people who are unable to work. But this is what we've planned for, and there is a number of actions in place to deal with it, including redeploying staff within hospitals and across the community, that can, and I know this has happened in some district health boards, redeploying DHB staff into aged residential care if it's needed, as well as those critical worker exemption schemes for people who are contacts, and even, although it's been used only on 1 or 2 occasions, the opportunity for staff who are absolutely critical, who have tested positive but are asymptomatic, to go back and work, but only with COVID positive people anyway. So there is a number of actions in place to help deal with that.
So there's no sort of percentage you can give, like, for example, I don't know, X% of primary care staff?
Look, the general figure we've had is that it does vary, but up to around 15 or 20%, and it varies by professional group as well. We know at some hospitals at Middlemore quite early on they had even higher proportion of their nurses off for several days, so that really did put a lot of pressure on.
Dr. Bloomfield, you said we need to keep our wits about us, but tomorrow we're looking at potentially quite significant changes to our COVID protections being announced. Are we ready for that? And should we be loosening things up?
Well, I don't want to preempt the PM's announcements tomorrow, but I will make the point, and I don't think there's anything that I'm going to say that conflicts with what the issues that Cabinet's been considering, and this reflects also the comments made by Dr. Mike Ryan from the WHO on the 16th of March. You know, we are still in the middle of a global pandemic. This virus is still very fit. It has thrown us curveballs before, and it will continue to. So we have, throughout the pandemic, adjusted our settings. As we come down off the peak of the Omicron outbreak, it's appropriate that we look at and I think adjust the settings. But we need to make sure we are ready for whatever comes next. And that may be winter, even just winter with Omicron and other diseases thrown in, but it may also be a new variant, and we need to be prepared to redeploy the measures that we have already in place or that we have used in the past, if the indications are right, and we'll keep a close eye on that.
Is it appropriate for the government to be using restrictions that were based to keep COVID-19 and its variants out of the community, to keep other illnesses such as cold and flu out of the community as well?
Well, these are exactly the things that the government's been considering, because there's this balance between making sure we're protecting the population and particularly our vulnerable groups, and making sure we are only using restrictions to the extent and for the time period that they are really indicated to be used. And again, this is what I think the Prime Minister will be announcing tomorrow.
And the assumptions that you've made today and the modelling, is that based on current settings, as in just as the COVID settings are today?
Yes, the modelling was based on what the settings were that were anticipated and or were in place ahead of the outbreak. And of course what we've overlaid there is what's happening with the actual cases. I do want to emphasise that we're not expecting cases to go back to zero. There will still be a reasonable number of cases. 3,000 to 5,000 would be the estimate we've got each day for some weeks, and that may well we may well maintain that level right through into winter.
Would you expect an increase in cases once restrictions are eased, though? You must have done some modelling and considered that.
Well, that's something we will watch, but again, I think you will see that the government's decisions have been fully informed by the current situation and the public health advice. And remember, even if we look at the COVID protection framework, you know, the next step from red would be to go down to orange, and that still has quite significant restrictions in it and or public health measures. And again, the key public health measures, the ones I talk about doing the basics well, include masks, they include distancing, they include staying home if you're unwell.
Just back to the...
Have you been able to offer the government any briefings on the legal aspect of using COVID measures in relation to the upcoming flu season? Is there a legal issue there of using measures that are designed and legally designed for one virus against another? Is that something that someone else does?
We haven't been asked for advice on that, and it hasn't been part of the discussions that I've been part of. What I would say, though, is, of course, as we get into winter, people won't be presenting with COVID. They will be presenting with what we call ILI, influenza-like illness symptoms. And so part of our preparation is thinking about how do we look after all those people. We've got at the moment a set of a set of arrangements in place, our care in the community, our testing and so on, that is specifically for COVID. And so now we're thinking about what does that testing look like, what does the care look like as we go into a winter where people may well have flu or COVID or another respiratory illness, or for children it could be RSV. So this is part of our planning ahead of winter.
Just back to the pressure on hospitals, has anyone with COVID had to be moved from one hospital to another because there weren't enough beds?
No, that's not something that I've heard any reports of. And all our hospitals had dedicated COVID wards and or have reduced provision, for example, of planned care when they needed to ensure there were beds available for people. I should say that in addition to people being looked after with sort of hospital level care in hospital, there is also a program, particularly in the northern region, of hospital in the home, so quite intensive support for people, but ensuring they can remain in their own home.
Dr. Bloomfield, just obviously as we head for peak of hospitalisations in the coming weeks and moving into winter, how many ICU or HDU patients could the health system cope with for COVID?
Well, I think we've traversed the number of ICU and HDU beds quite a bit. What I would say is that at the moment, our total ICU and HDU beds are about 60% occupied, and that's been quite consistent. We've got today 25 of those, around 300 beds. 25 have got COVID, people with COVID in them. And of course, it's one thing to have a bed, but you need the staff, of course, for those beds. And so every day the hospitals are looking at what's the projected number of people they might need in ICU or HDU and staffing those beds accordingly.
Is it still
Just looking at the 15 deaths, were those overnight? Just confirming they're not the ones that are counting ones that may have happened in the past week or so?
We're now reporting deaths that have come through in the last 24 hours. A couple of times in the last 2 or 3 weeks there's been a sort of bit of a backlog, as it were, and you'll recall last week we reported on one day 24 deaths, and 16 of those were ones that had come through over the preceding 2 or 3 weeks. We feel we're up to date now with the reporting, and so the figure each day is pretty much the number of deaths from the preceding 24 hours.
And yesterday it was someone in their 20s, and over the weekend in New South Wales, a child aged 2 died from COVID-19. What does that tell you about this virus, or what should that be telling punters around the country who might not be taking things so seriously?
Look, I think everyone understands that for some people, including people who were previously fit and well, like tragically the young child in New South Wales, they can get seriously ill and sometimes die. So this is not a trivial infection. And again, if we think about the number of flu-related deaths each year, it's around 500 or 600 in New Zealand in a typical flu season. We haven't seen that in the last couple of years because the borders have been shut. But if we think about around 10 deaths a day from COVID in New Zealand, and we don't expect that necessarily to go on and on right through to the end of the year, but that's well over 3,000 deaths a year. So this is clearly not, even though Omicron more mild than earlier variants. This is clearly, a significantly more deadly virus than flu, and part of that is because it's way more transmissible. So the biggest driver of hospitalisations and deaths is simply the number of cases there are out there. So I want to encourage everybody to do everything they can to reduce the risk to themselves and others. Vaccination is by far the most important thing there. So there's a question or comment over here.
Did you brief Cabinet on Monday with the Ministry of Health's perspective about the ongoing restrictions, the vaccine mandates, and the other one that the Prime Minister is currently considering?
I didn't brief Cabinet myself, but we have provided input into the advice that went to Cabinet on Monday. We have provided that advice over the last 2 weeks, a number of discussions involving colleagues and ministers across government.
Was there a representative of the Ministry of Health in the Cabinet meeting on Monday giving this advice?
No, there wasn't.
Isn't that a bit unusual? In the past, when they've been making these big decisions, there's usually yourself. You've been to more Cabinet meetings than any other public servant in history, probably. So how come you weren't there personally?
Well, for a time, yes, especially as through the first couple of years, we were in our elimination strategy and things were evolving so rapidly. And very often I was briefing Cabinet with the latest data on the day to inform decisions that were quite significant, usually around alert level changes. We're in a different phase of the pandemic now, so I haven't been involved in briefing Cabinet directly, but clearly health input is a very important part of those briefings that Cabinet gets through the Cabinet paper.
Yeah, and just on the other variants, you said that we're still in the midst of a pandemic and have to be prepared for new variants. Does that mean that lockdowns aren't off the table?
That's a decision for government. It's not something we've discussed, but it was really just to be clear that it's the Omicron variant the Omicron variant is the first of these new variants that has been both more transmissible but less virulent and less virulent. The earlier ones have been more transmissible and more virulent, more deadly, you could say. So there's no reason to believe that the next variant is going to follow the Omicron pattern, and this is something the WHO and others have pointed out. We need to remain prepared and recognise we're still in the middle of this global pandemic.
Are you concerned about Deltacron then, that they're saying around the world?
Not specifically. I think it's very emergent, but at the moment I think it's the Omicron variant that's really the one that's causing the most problems globally. Final question.
On mental health. The Mental Health and Wellbeing Commission has suggested the $2 billion wellbeing budget appears to have made little difference to specialist services. When do you think that mental health services will tangibly improve for New Zealanders?
Well, the $1.9 billion that came through in budget 2019, and around 2/3 of that was for the health system. The critical investment there, and the Mental Health and Wellbeing Commission know and support this, was for primary and community-based mental health services. And there's been a big investment in that area, and there is a range of services available now through general practice, through Māori and Pacific and youth providers that were simply not there 3 years ago. And that's where the focus has been. And part of the reason for that investment is to try and avoid the need for people to then require more specialist care. So saying, district health boards have continued to invest in specialist services year on year. But the big challenge there, and this is one that Minister Little pointed out this morning, is workforce. And there is a number of initiatives underway to expand and grow the workforce, the specialist workforce, to help support that increased demand there is for specialist services. So it's not a short-term solution, but the $1.9 billion and the health part of that was specifically aimed at growing primary mental health services. And it's great to see that there is a range of services now available that simply were not there 3 years ago.
So Dr. just following on that question, so just thinking about our sort of senior clinicians, that would take about 7 to 10 years to sort of build that workforce up. So I suppose New Zealanders are potentially looking at another 7 to 10 years of a mental health crisis.
Well, there are many ways one can grow the workforce, and part of that is, of course, the borders are going to be open again, so that gives an opportunity to strengthen that workforce. But in particular, and this is the basis of the primary care workforce, mental health, is grow new workforces. And so that essentially those services now being provided to thousands of people every month is a workforce that wasn't there previously. So we will continue to look at ways to do that, and as at the same time we grow the specialist workforce. I should say it's a global challenge. Mental health workforce, particularly psychiatrist and psychologist workforce, is a real challenge.
Would you characterise it like that? Do you think we have a mental health crisis in New Zealand?
Look, you're probably aware I'm not a huge fan of the word crisis because I think it's used really liberally. There is no doubt we have significant mental health issues and challenges in the country, and the health system is one part of the response to that, and there are big workforce challenges there, and that's why the government has made this big investment there. What I would also say is I'm very thoughtful about the mental health and wellbeing impact of this experience through the pandemic, and I think that's something we need to be really alert to, and thinking about how we support individuals, whānau and communities to kind of maintain and improve their well-being as we go through, as we come into this third year of the pandemic. And that's a role for all of us, not just for mental health services.
And you said that for the foreseeable future we're going to have in the low thousands amount of cases going forward. Is COVID just something that we in New Zealand and indeed the rest of the world just have to live with for the rest of our lives?
I think COVID will be around for good, just as the first reported or known reference to influenza was in about the 11th century. It's something that's been with us. COVID, like other coronaviruses, will be here to stay. The question is just what sort of impact it will have on individual countries, communities, and globally. We're only 2 years into this virus having appeared, and so quite what the future holds, none of us know, but we need to be prepared. Good, thanks very much. Oh, sorry, is there one final question?
Vaccination rollout. Last week, Dr. Shane Ritchie said that the government's missed an opportunity to have rolled out the MMR and the COVID vaccine at the same time. He said he's claiming around $8 million worth of MMR vaccine are going to waste. Is it possible to roll out both at the same time, and are any providers doing this?
So this is something we have looked at because in particular for that age group, about 15 or 16 up to just over 30, where we know they're under-vaccinated, that's where we've been doing our catch-up campaign, and we've been looking at that for some months. Actually, logistically, it just didn't prove possible to do, partly because many of our vaccinations are being given out and have been the COVID vaccinations through those drive-through centres and our big vaccination clinics, and the vaccinators there are trained just to give the COVID vaccination. So logistically, it didn't prove possible. However, we have got some very advanced work on this, and within the next couple of weeks, we're planning to really ramp up the campaign to increase our MMR vaccination rates amongst tamariki at that 12 and 15-month vaccination, but also that catch-up for those 15 to 30-year-olds, and looking to see if we can do that alongside the COVID booster. So that's work in progress. Thanks very much, everybody. See you again.